Καλησπέρα στην αγαπημένη μου Κύπρο. What I will try to share with you is some thoughts about issues that are pertinent to COVID-19 on models, evidence, risks, how do we choose the best interventions. I think it's interesting that in this symposium you will hear different perspectives, perhaps complementary perspectives. There will be some agreement on some points, probably disagreement on other points. What is my view about COVID-19? And I need to start by saying that I have no conflicts of interest in anything that I will share with you today. Let's go through these statements. COVID-19 is a very serious threat. It is very unpredictable. It is the pandemic of a century. It's similar to 1918 influenza. It is the top cause of death in 2020, outpacing all other causes. And it is the infectious disease that has killed more people than any other in our generation. How many of these statements are true? It is clearly a serious threat. It is clearly very unpredictable.
Sorry, I can't like that.
It is not the pandemic of a century. It is not similar to 1918 influenza by any means. The person years lost with COVID-19 to date are about 1,000th of 1918 influenza, where we had about 50 million deaths, and the average age of death of people was 28 years old. It is not the top cause of death in 2020. It is not outpacing all other causes. For example, smoking will kill another 9 million people this year, like every year, just as one example of a major killer. And it's not even the top infectious disease in the planet. Tuberculosis has killed 1 billion people in the last 2 centuries. It still kills fewer than it did in the past, but it kills about 1.5 million people every year. These are mostly young people or middle-aged people. And lockdown measures for COVID-19, if prolonged or if repeated, they risk killing an estimate of 1.4 million extra people with tuberculosis in the next 5 years. Again, mostly young people.
I'm sorry.
Who would have done much better as we're managing tuberculosis far more efficiently in the current environment before COVID-19. Now, as I said, COVID-19 is a serious problem. I would not wish to diminish its importance. I think that we need to take it very seriously, both as a pandemic and also as the consequences of the pandemic, because there's lots of things that can go wrong unless we do that. And now I seem to have missed the presentation again. Oh, goodness. Let's see. Okay, we're back. So there are lots of conspiracy theories out there that this is a manufactured virus, that the virus does not exist, that some conglomerate of companies or evil people thought about designing this. And I think that none of that, of course, is true. This is a bioarchive paper, a preprint that suggested that there's similarity between HIV and COVID-19. And obviously, this is not true. It's not that this is a virus that was manufactured. So we have to get rid of all the conspiracy theories, everything that really gets us out of the scientific rationale of what we're dealing with. But there are issues that even in the best scientific efforts, we have a lot of statements that probably are exaggerated. Let's go through a number of them. 80% of the global population will be infected, very rapidly so. There's some debate about how many people have been infected already. My estimate is about 10% of the global population has been infected within that first year, and I think that more people will be infected. I think it's unlikely that we will get to 80%, and I will show you some data. Early data suggested that we have a 3.4% case fatality rate with few or no asymptomatic patients. The envoy of WHO to China found very few people who had no symptoms, and therefore, if you think of no asymptomatic infection, that means that the infection fatality rate, the chance of dying if you get infected with this virus, is pretty much similar to the case fatality rate, the chance of dying if you are diagnosed with carrying the virus. Later, the infection fatality rate was dialed back to about 1% or a bit above 1%, but it is still very high. in many places that you will see, especially in media and social media. And based on such calculations, wonderful scientists at Imperial College, very experienced in modeling, estimated that we will have a massacre that would be equivalent to 1918 influenza. So if you run the calculations with an infection fatality rate of 1% or 0.9% and 80% of the global population to be infected, you end up having way above 50 million deaths, including 2.2 million people dying in the US alone. And this would mean that we would have entirely overrun healthcare systems. For example, these are some news stories from reliable news media back in March, where people were thinking that we will be seeing in every single state, in every single country, what we had been seeing in Bergamo or a few locations in northern Italy that were completely overwhelmed. So people were thinking, for example, for California, that we would need another 50,000 additional hospital beds very quickly within a matter of weeks, or in New York, we would need up to 140,000 hospital beds. Now, what happened is that some places were hit very hard, but nothing close to these predictions came to happen. And what we had seen in Bergamo and a few places in Lombardy, that in a paper that I wrote with the leader of the Italian COVID response, Walter Ricciardi, and my colleague at the University of Rome, Stefania Boccia, we tried to dissect what happened in Italy. We didn't really see that happen again, with some exceptions. We saw most places not being hit at all or hit very lightly, and we saw some places hit more, and a few places really hit enormously and in a devastating way. Our forecasting seems to have fared pretty badly. And this is a paper that I wrote with Sally Cripps from the University of Sydney and Martin Tanner from Northwestern, trying to understand and dissect why our forecasting was not doing what it was supposed to do. And I'm not saying that it was bad scientists or scientists who were not well-intentioned who did that forecasting. I think they had the best intentions and they tried their best tools. We tried our best, but simply our forecasting, all of us, we just didn't manage to get it straight and to get it right. Here's one example. This is 4 models that were produced by extremely prestigious teams, the IHME team at the University of Washington, the Los Alamos team, University of Texas, and YYG. This is the ability to predict not what will happen 6 months down the road, but just predict what will happen next day with less than 10% error. And if you see blue color, this is really close to 0%. If you see red color, this is about 40%, but really not that great. Almost in all days, these models could not really predict well even what would happen the next day, let alone in 6 months from now. If you ask whether these models had at least the right uncertainty, because you can make a prediction that is not right, but maybe you allow for enough uncertainty that your confidence bounds would allow having a value that is within what eventually happens. Even then, you see lots of blue color. The University of Texas model does a bit better than the others, but actually, most of the time, most models, even when we take the wide uncertainty that they incorporate, they would not have very good predictive ability. What we have seen is that some of that failure to predict is due to our mishandling of how epidemic waves for COVID-19 are evolving. For example, this is what is happening in the first 6 months in different places around the world that were hard hit. You can see that if you exclude India and Mexico that were very early in their course, we had almost all the other places follow what are Gomber's functions. They're not exponential functions. They're functions that are sigmoid. They reach a peak and then they're curving down. And even in Mexico and in India, we start seeing that pretty much in the same fashion. When I plotted these curves, it was earlier in the course of the epidemic wave in these places. So that would explain why our models, why our efforts, and of course that includes my efforts and efforts of some of my best friends and colleagues, could not really manage to get a very accurate picture of what would happen. What we have realized, nevertheless, is that there are some solid features about the course of the pandemic in terms of its epidemiological footprint. This is the age distribution of deaths in the first 6 months of the pandemic. So this is capturing the first wave in the places that were the most hard hit around the world. And as you can see, the majority of deaths typically were in people above 80 years old. Typically, the median age of death was very close to the life expectancy for the respective population. Not surprisingly, Mexico and even more so India are different because they have a much younger population, and again, the life expectancy is much lower. If you look at the number of deaths in people below 40, they're really a very, very tiny minority, and even deaths at age 40 to 64 are still a small minority. This has been seen in many different countries, and it's pretty consistently shown if you look at the comparison, for example, of death risk in people above 65 versus those who are less than 65, that the difference in the risk is about 50 to 100-fold. In some US locations, it's a bit less, about 15 to 50-fold, but still, this is a very stark difference. And if you take extremes like children versus 80-plus-year-old, you will end up seeing risk gradients of 100-fold difference in terms of the risk of dying. And pretty much the same applies for severe disease. These are data from a paper published by the Open Safely team in the UK in Nature. Separate curves for females and males. Males have a higher risk of an adverse outcome. But again, you see that very steep differentiation of risk as you go across young, middle-aged, and elderly people. If you try to estimate what the death risk is, to translate it to an equivalent of a daily activity, if you take daily commute, driving a car, and you take the first 6 months of the epidemic wave in the most hard-hit places around the world, and you try to convert the daily risk of death to the equivalent of how many miles one would have to drive to get the equivalent risk of death on a daily basis, this is what you get. In most places, the risk of death in people less than 65 years old, even in the most hard-hit places around the world, is in the same ballpark as driving a car for daily commute. Now, there are exceptions. For example, New York, it's not the average person, but it's more like a truck driver who's driving from Manhattan to Baltimore on a daily basis. But many people do that for a living. So they would drive these hours on a daily basis. And of course, they have never thought that they are doing something that is going to kill them necessarily. If you look at people who are less than 65 and have no underlying disease, it is even better, because the few deaths that we see in people less than 65, most of the time they're associated with substantial comorbidities. If you try to isolate deaths that occur in less than 65-year-olds without underlying comorbidities, then we're typically in the range of less than 1%. You see some numbers that are a bit higher than this, like Sweden is 2.2% and France is 2.6% of all deaths happening in less than 65 without comorbidities. However, the reason for that is that the definition of comorbidities is very restrictive in these calculations. So for Sweden, only 4 comorbidities have been considered. If you were to add other comorbidities as well, the percentage would substantially be decreased. There's also several clinical factors that modulate the risk of death and poor outcome. Some of them have substantial impact on the risk. For example, organ transplantation or severe immunosuppression, or having leukemia very recently, or having a cancer that is not treated yet, or having diabetes that is completely out of control. All of these factors would increase the risk of death about 2 to 5-fold, which is pretty substantial. At the same time, if you're looking at things like hypertension, it doesn't really increase the risk of death. If you're looking at something like mild asthma, it doesn't really increase the risk of death. If you're looking at something like controlled diabetes, it does include the risk of death, but it may increase it by 1.3-fold, so the impact is pretty modest. This is a typical pie of the population in a European country. For example, if you take Cyprus or most European countries or the US, you have a very large share of the population being less than 50 years old. In Cyprus, the median age is about 35. You have a thinner slice that is 50 to 65. You have about 12 to 15 or 17%, depending on what country you're talking about, that is more than 65. And you have typically a slice that is very thin of people who are in a nursing home. In the US, it's close to 0.5%. In most European countries, it's pretty much in the same range or a bit less or a bit more. Those people who are at nursing home are at tremendous risk. Their risk of dying if they're infected, 1 out of 4 will die. Those people who are above 65 and have other comorbidities, they're also at pretty high risk. Those who are above 65 and have no comorbidities are pretty functional. They have some risk, but it's far, far lower. Of course, those who are younger, as I said, they have very minimal risk. Of course, nothing is zero, but it's really minimal. If you translate these numbers to the proportion of deaths that happen according to different age risk categories, this is what a typical pie chart would look like. We see in most European countries that nursing home deaths account for about half of the fatalities, and then about a third of the fatalities is happening in other people who are above 65. They're not institutionalized, but they're high risk. We have also some other people who are younger. As I said, they have very severe diseases, like they have had organ transplantation or they have active leukemia and cancer. They need to be very highly protected, and they are also at very high risk of fatality. But very few deaths are contributing outside of these thin slices at the level of population proportion. As you're very well aware, we had to respond very quickly. And when we first met that new virus and we saw these horrible pictures from Italy and from China, we had to do something. If really it was a 3.4% or even a 1% or close to that, it was something that would infect 80% of the population. That was really horrible. So any measure was justified at that first instance when we didn't know what we were dealing with. Lots of measures were taken involving different forms of social distancing, and some of them went to extremes of horizontal lockdowns. There's hundreds of measures that are included in the bundle of social distancing and lockdown. Their implementation is rather arbitrary. If you look at the way that different measures are implemented in different countries and the sequence that they're implemented or relieved, there's such a vast array of things that can be done that there's really no perfect recipe on how exactly that should be done. There are lots of randomized trials, more than 1,500 ongoing or planned trials on COVID-19. Actually, only 2 of them are on social distancing measures. And what do we even mean by social distancing and lockdown? Is what we do now a lockdown compared to what we were doing in March? Does it make a difference? What exact measures are we implementing? How can we test these measures? All of these are questions that we really don't have a good answer, because we need to agree first, what is it exactly that we want to do? What are the types of outcomes that we want to decrease? For example, do we want to decrease documented infections? I would argue documented infections is a useful indicator, but it doesn't really tell me much. I would feel okay if I have documented infections, but people do not get sick, if people do not get to the hospital, if people do not have to go to the ICU, if they do not die. If I have documented infections, this doesn't mean much. Conversely, I could have documented infections and people could die or be in the hospital or in the ICU. So it's important to understand that the metrics that we are easily capturing are not necessarily those that we want. Another issue is, what kind of outcomes are we interested in? Are we interested on what will happen right now? Are we interested on what would be the effects on our healthcare system, on our society, on health in multiple dimensions, in the midterm, in the long term? We know that many of the measures can be devastating in terms of their midterm and long-term consequences, and they could really kill millions of people, perhaps, if they have to be prolonged. How do we collect outcomes? If you're thinking, for example, about the long COVID syndrome, do we wait for people to come to us, or do we actively seek to try to find out how they feel and what kind of symptoms they have? What is the long-term relevance of all of these measures that we can capture right away? Because obviously we cannot wait for 10 years. We need to act now. What is their cost effectiveness, and what is their placing in context to broader gains and risks? For example, effects on economy, on the environment, on society, health system at large, health with capital H. To answer these questions, we need to understand what kind of an enemy we're dealing with. So a first question is, how widely is this virus spreading? How common is the infection, and also how lethal it is? There's multiple seroprevalence studies that have tried to answer these questions. And some of the early ones came under fierce attack when they found very widespread of the infection and correspondingly low infection fatality rate in the range of 0.18 to 0.28%. For example, the Santa Clara and the Gangle studies came under a lot of fire because many people thought, well, we've heard about 3.4%, we've heard about 1%, maybe 0.9%. How can you come up with a 0.18 or 0.28 even? A couple of weeks ago, I published a paper in the Bulletin of the World Health Organization where I looked at 82 studies with analyzed data, and the median infection fatality rate was 0.23%. So it is really in that ballpark. And actually, if you look at the infection fatality rates across locations, they seem to be pretty different. But if you look within the same location, they're relatively consistent. For example, Brazil always tends to have values that are very close to 0.2, 0.3, 0.4. California is pretty much in the same range. Japan or India, they tend to be much lower. Louisiana is much, much higher. New York tends to be higher. Spain tends to be higher. So there is heterogeneity across locations, but there's consistency within locations in these different studies. And if you plot the numbers across the impact of COVID-19 in terms of the total numbers of recorded deaths, and that includes both deaths with and from COVID. I'm not trying to differentiate here. It's just deaths that have been counted somehow as having COVID on board. You see that there's almost a linear relationship, meaning that places that were hit very hard, that had lots of deaths, they have also higher infection fatality rates. And this is very easy to explain. It's not a surprise. If you have a location where nursing homes are decimated, as I said, nursing homes, they have 25% infection fatality rate, not 0.25, but 25. It's like 1,000 times higher. So these places will tend to have also an infection fatality rate that will be very high. But it doesn't mean that the vast majority of the population, the people who are not in the nursing homes, would have also a high infection fatality rate. There's other features. There's issues of management. For example, many places used a lot of hydroxychloroquine, and based on what we have seen, hydroxychloroquine seems to increase mortality as a therapeutic option rather than decrease mortality. Other issues of management, whether people were ventilated, how good the healthcare systems were, how well prepared they were, whether they did protect their elderly and susceptible individuals, and so forth. If you put the numbers together, as I said, the median is 0.23%, and I would argue that if you correct for the fact that the vast majority of these studies were done in locations that had the highest death toll, it's probably in the range of 0.15%. So something like 1 out of 600 people in the general population being infected. Among the people who are less than 70 years old, the median is 0.05%. And again, if you do that correction, you'll probably end up with something like 0.03 to 0.04% on a global level, which means that 1 out of 3,000, 1 out of 2,500 people is likely to die among those who are less than 70 years old and get infected. But again, you see that stratification, that the numbers are even better in places that avoided massacres, like nursing homes, and they're pretty high in places that couldn't avoid these massacres. And hopefully, they can avoid them in that second wave that is coming. What we have learned is that COVID-19 is not a single disease, is not a one-size-fits-all. It is something that can vary a lot. It can be much more mild than influenza, and it can be devastating compared to influenza. The infection fatality rate is not a constant. It's not like the gravitational constant or the Km of an enzyme. What we will get at the end of the day depends on the case mix, the population structure, who are the people infected, how people are treated, and many other factors. The good news is that since we know many of these factors now, we can make the infection fatality much lower. So this is how I think we should go. Use this scientific information to try to amend the factors in our favor. The next important question is how many people have to be infected? I wish we have a vaccine next month that can be used by everyone, that is completely effective, that is safe, that everyone will agree to take it, that it has no problems at all. But as you realize, this is not likely to be a realistic scenario. I do believe that vaccines are great conquests of humanity and of medical science, but we need something that will be vetted and tested and proven to be effective and proven to be safe and proven to be possible to use in a large scale before we can say that we have victory. So where would we need to get to stop this thing? Maybe it will not stop ever. Coronaviruses are with us. They stay with us. They come back. They have some outbreaks now and then. We live with them. So maybe that's what's going to become of that coronavirus as well. But how about that first pandemic? Do we need to get to 60%? Do we need to get to 80%? Because, of course, some models even go to 80%. These quotes assume homogeneity of mixing of populations. They assume that I have an equal chance of meeting you in Cyprus, meeting my wife in California, and meeting my mom in Athens. Or, if you are in Cyprus, you will meet with everyone in your city. You have an equal chance of meeting with everyone in your city. And as you realize, that's not the case. Populations have some sort of quote-unquote segregation. They're avoiding mixing with everyone for whatever reasons. We mix with some people, we have some friends, we have some people who we work with that we communicate. This means that if you correct for that heterogeneity of mixing, it means that you don't need to get to 60 or 80%. You may need to get only to 10, 20, 30% before that pandemic wave will be pretty mature. The second waves, we just don't know how high they will be. We just need to be prepared for them. We see now that they're pretty high, but in most places, they're not coming together with very high death toll. Does this mean that we have learned something, that we have managed to avoid having them hit the most vulnerable, the most susceptible people, and therefore their impact would be less likely to be as severe as it was in the first wave? Do we have a bonus from other coronaviruses? Perhaps. There's some evidence that 20 to 60% of unexposed population already has some cellular immune responses to SARS-CoV-2, suggesting potential cross-immunity from garden variety coronaviruses. And this may explain why the epidemic waves may stop with relatively low percentages of people being infected, or at least people having less severe disease in many of the new coronavirus infections. So this is something that is still evolving knowledge. Asymptomatic infection, how important is that? It is common. I think that based on what we know now, both my team and other teams have found that a very large proportion of people are either asymptomatic, but still have positive molecular tests, or they have some symptoms that these symptoms are so mild and so nonspecific that they just don't get tested. Especially in the first wave, very little testing was done. So we kind of missed all of these infections. Now, are these really infections? I would count them as infections, but we have to differentiate between someone testing positive and calling that an infection because of positive molecular test versus someone who has an infection and is ill because of that infection. Most people who have a molecular test that is positive are not sick, or they're just having some symptoms that are not really affecting them in any major way. They can still transmit the virus though, and I think that about 1 out of 10 of these people could transmit the virus to others. And if you take into account that we have lots of them, you do get to see people transmitting the virus without having symptoms. We haven't really realized that they have SARS-CoV-2 that they're carrying with them. And this is a model that we recently published with Ellen Kuhl from Stanford, where we try to model the implications of asymptomatic infections and try to understand the spread of the virus in the community and also what it means in terms of trying to halt an epidemic wave. We don't want to treat asymptomatic people, but we want to avoid having them spread the epidemic wave to people who might be vulnerable and eventually get substantially sick. How do we do that? As I said, we have no trials about how to do it. We have some trials from the past. We have a trial on masks in people who are infected with influenza, and masks seems to be a good thing for them. We have another trial for people who are treating people or getting in touch with people with influenza. Again, that seems to be a good thing. We don't have really any trials on masks for COVID-19, randomized trials. We have one trial done in Denmark. Apparently, it seems to have negative results. Masks do not seem to work, but The trial has come under scrutiny even before being published. Its design was aimed to assess whether people who are wearing the mask will get a lesser chance of getting infected. And apparently, even though people have not released their data, it seems that they found no benefit. But we're not really doing it for this. We're doing it for people who might be infected from us if we are infected. So I think that we need to be a bit careful about making strong statements about what we know and what we do not know. When it comes to treatments, as I said, we have a flurry of trials, and many people, especially clinicians, desperate to give treatments. They started giving treatments that was completely well-intentioned to try to save people, especially those who are more severely sick. Based on what we know now, unfortunately, some of these treatments are not effective, and some of them may have been harmful. For example, we just this is just the growth of trials, about 1,500 trials launched within a few months. Very few of them have been completed. Many of them probably will never be completed. I think most of them will be abandoned. We have one success. We have dexamethasone that seems to decrease the chance of death about a third in those who are very sick. Remdesivir, I'm not really convinced. It doesn't seem to save lives, although maybe it can shorten the duration of illness for people who are in the hospital. This is one international meta-analysis that my team put together with data contributed from 28 teams around the world looking at hydroxychloroquine as treatment. Unfortunately, that's bad news. The risk of death goes up about 10%. And with the latest update that we just uploaded in a revision, it seems to be even substantially significant, not both clinically and statistically so. So we're back to our social distancing measures. We're back to our lockdowns that policymakers are thinking about and contemplating and speaking of, and lots of people are of course, denying to follow because they're very draconian. Do they work? This is from a classic paper in Nature by the Imperial College team. As I said, they're wonderful modelists, and they published the top panels that show here what's happened in the UK, and they run calculations for other countries as well. Their model suggests that lockdown, among all the other measures that were used, lockdown was the one that really managed to get the basic reproductive number down substantially, and eventually save the day, save lives. And of course, if that's the case, we need to take it very seriously, because it may have devastating consequences on other fronts, but if it saves lives, that's really wonderful. Well, Imperial College used also a second model that they also published separately, and they applied it not to European country data, they applied it to states, to American, US states. And we applied that second Imperial model to the European data. And when you apply the second Imperial College model, lockdown has absolutely no benefit, absolutely no benefit. And actually, the fit of that second model is much better compared to the fit of the first model. So that's really very weird. The best fitting model shows no benefit. A very weird, poorly fitting model shows a benefit. What do you trust? Well, we tried other models, and again, we didn't really see much of a benefit with lockdown. What we did see is that people did try to stop some of their mobility. They became more careful. In Greece, for example, they became more careful before the lockdown measures. It seems that their mobility started decreasing, their meeting with other people, their exposures decreased. And this happened pretty much in every country. It happened in Sweden, it happened in South Korea, in countries that did not apply lockdown. So I think that one could avoid exposures, at least heavy exposures. I'm not saying to diminish life and destroy life, but avoid heavy exposures to congested settings where you don't need to be there, and use measures like hygiene, mask when you have to be in congested places with other people, or indoors with many other people sitting next to you that they're not your direct family. But you don't need lockdown. Lockdown is only going to cause harm, and it's going to cause harm in many, many different ways. We saw that already in the first wave, and I think we will see, unfortunately, more in the future if we continue to use that recipe. We've seen, for example, that there was an increase in the numbers of people dying from acute myocardial infarction and other acute diseases because they were not given proper hospital care. People were very much afraid. They were scared. They didn't go to the hospital. You need to go to the hospital. If you have a heart attack, you cannot really stay at home. So this is one easy way, unfortunately, that we saw an excessive death. We saw people with cancers that had delayed treatments because everything stopped because of that pandemic wave that was not coming to overwhelm the hospitals, but people were not getting treatment for cancer. And I think that we will see these deaths coming in the next 5 years because people will not die immediately, but they will die because they had suboptimal care. We had disrupted cancer prevention with pretty much the same impact. We will see these deaths coming in the last 5, 10, 20 years. We had complete health care disruption with postponement of cancellation of elective procedures, regular care, things that do matter. We had suicides and mental health disruption. We have many surveys that suggest that lockdown made 50% of the population depressed or anxious, and about a quarter of young people had suicidal ideation in the US. We had violence. We had, at a global level, the problem of starvation, with disruption in food production and transport becoming a bigger and bigger problem in low-income countries, because if you shut down the economy, you shut down transportation, you really have hundreds of millions of people at the brink of starvation. You add another 100, another 200 million people who might be starving in the near future. Tuberculosis, I mentioned that we run the risk of an extra 1.4 million deaths of young people in the next 5 years. Childhood diseases because of disruption of vaccination programs, alcohol disease, other diseases of despair because of unemployment, or because of people losing their jobs, losing their hope, losing their lives and their future. We just cannot do that. Multiple chronic other problems, and even destroying our basic healthcare system. The healthcare system needs to be financed. You cannot really find money on a tree. It needs funding, it needs resources, it needs support. If you destroy the economy, we cannot have healthcare. We cannot have primary healthcare. We cannot have tertiary healthcare. We will have deaths from all other causes accumulating. What the future holds, it's very hard to say. We know that pandemic waves for a new virus, when it is introduced in the community, may take a couple of years to run their course. It's not just 1 week or 2 weeks. I think that many leaders in March thought that, well, I will close the country for a couple of weeks and I will win and carry the day and it will be over. No, this is a marathon. It's something that will last probably at least a couple of years. Actually, with our efforts to stop it at all costs, it's likely to last longer than it would have run if we just happened to be, let's say, in the 18th century, we just couldn't do anything, or had not even realized that it was out there, and then it might stop earlier, but obviously with a potentially higher death toll. So here's a stratification of the global population. We have about 10 million people who are institutionalized, frail elderly people. We have another 250 million who are over 75. We have 450 million 65 to 74, another billion of people who are upper risk less than 65, and 6 billion of low risk less than 65-year-olds. 7.7 billion people, if you run the calculations under different assumptions, if we get to 60% of the population being infected, which I don't think will happen, but let's say if we have like the full herd immunity, we have no vaccine, everybody mixes with everyone else, we have nothing to stop it, and we get to 60% everywhere, not just in Mumbai or in some low-income places in Latin America, but everywhere. Then we're talking about 8.8 million deaths over 5 years. As a comparison, seasonal flu over 5 years is about 2.5 to 3 million deaths. And actually it includes lots of young people and lots of children. And these 8.8 million would not include really many or hardly any children or young people. If we get to a 30%, which I think is more realistic, then we're at 4.38 million. I think it's far more realistic. And if we can protect people who are at high risk, for example, if we make them be infected only half the time compared to the low risk people, we're down to 2.28 million, where we're halfway, if that's the case. If we can protect them even more, we're down to 1.58 million, which would be really great because it means that we are at 1.1 million already. Obviously, we've had a lot of mistakes in the early management, and that 1.1 million, we could have avoided probably about half of that. But it's really up to us to decide how we want to handle that. And I think if we modestly protect those who are at high risk, we can really get substantially better outcomes. Of course, there's other factors to affect the toll. Vaccines. I hope that we have them soon, but you never know, and we may never have them. Who knows? There's uncertainty about their successful development, about availability, about effectiveness, about safety, about uptake, about coverage of high-risk populations, about impact on transmission, about duration of protection. All of these are pretty much unknown at this time. Maybe we could develop some more effective treatments and management options, or at least avoid the detrimental ones like hydroxychloroquine. The impact of economic and social disruption on the course and management of the pandemic, I think could be really major. If we manage to destroy our countries and the world, then we're not talking about just COVID-19, which might be 0.5% or 1% or a bit more at the most of all deaths. We're talking about 300 million deaths happening for various causes around the world over the next 5 years. We're talking about far more serious problems. Public health and personal hygiene measures could make a difference. We don't know how much, but I think that we should try to do our best without disrupting society at large. Interplay with other emerging health problems, for example, respiratory infections like influenza. Influenza seems to have disappeared or at least decreased in the Southern Hemisphere during the advent of the coronavirus waves. I think people should get vaccinated for this winter, but maybe we don't see also an influenza wave while we see a coronavirus wave. Or maybe we do see one. That's something that we need to see, but I would like to feel that the optimistic scenario is more likely. Reinfection, people are talking a lot about reinfection. I don't think that we see much of that, at least in the short term, and I don't think that it will make a big difference, but we have to track it. Chronic disease, again, something that we need to track, who knows, but I'm relatively optimistic. And finally, catastrophic chaotic events, wars, riots, revolutions, things that are very disruptive. If you get people crazy, if you get them so anxious, if you get them mad, then you're destroying really everything. And we need to avoid that. We need to remain calm. We need to avoid panic. We need to just not think that this is the end of the world. It is not the end of the world, but we can make it become the end of the world if we do the wrong things. So what should we do? I think testing. I have been a very strong proponent of testing in the early days. I think if we test early on, before you have an epidemic wave, then you can contact trace and stop the epidemic wave. But that means that you need to keep going until you have a vaccine, because if you relieve the tension on testing, you will probably have an epidemic wave. But Singapore and Taiwan, for example, were very successful. Singapore had 58,000 infections with only 28 deaths today. If you manage to suppress a wave, you can hope that testing will pick resurgence for a second or a third wave. I have also argued that we need to do very rigorous epidemiological surveillance on representative samples of the population. There's different ways to do that. We can go into the technical details if you wish, but otherwise, if we just wait for people to come to us to get tested, that just says nothing. I mean, if you do more testing, you will get more infections detected, but it doesn't really mean much. Employ the information on the risk distribution. Don't ignore that. We're talking about a disease that is nothing or completely lethal. And we cannot deal with these two extremes in the same way. 90% of people can go along their lives pretty much in a normal fashion. Of course, they need to protect others, but they can live in a normal fashion. 10% we need to protect, 0.5% we need completely draconian measures. Hospitals, nursing homes, hygiene, draconian hygiene, infection control, draconian infection control. Test all personnel, test residents regularly, more frequently in periods of resurgence and activity of the epidemic. We need to protect these people. That's a very small proportion of the population that will need extra measures. We have some other high-risk settings like some types of jobs, meat processing plants, prisons, homeless shelters, ships. For the rest, the vast majority of the population, I would say, live your lives, use hygiene, hand washing, respiratory etiquette, masks whenever they're appropriate, some non-disruptive distancing. Keep living, keep protecting yourself and others, but don't get too anxious and too depressed. Don't get anxious at all, I would say, and not get depressed at all. COVID-19 also is a disease of inequality, and it creates even more inequality. So we need to protect the disadvantaged. If we say lockdown, we think that everybody is sheltering at their happy home. That's not the case. It's wealthy, healthy people who protect themselves. It's people like me who give lectures on Zoom. The poor, the disadvantaged, those who are really sick, they're out there working because they have to make a living. They have to go to work. They are essential workers. They're out in the street. They're homeless. Lockdown does nothing for them. Actually, it victimizes them. It saves me, who I don't need to be saved, and it kills people who need to be saved. Eventually, we should do our best not to destroy the whole world with aggressive measures. Please, I think that leaders need to realize that this is a problem, but it is manageable. It should not be made a far worse problem based on the measures that we're taking. To end, here's my proposal. This is a paper that I wrote with Prabhat Jha from Toronto, and it's coming out next day in Lancet, tomorrow in Lancet Global Health. We are proposing that since we are doing all these crazy measures, we should do something right. If you want to do something really disruptive, during the COVID-19 pandemic, we have destroyed most businesses, most markets, most of the economy, most of our health. We have destroyed everything. Well, let's do something right. Let's take as an opportunity to eliminate the tobacco industry. We can do that, and we go through the points of how exactly this can be done. Just to give you a comparison, Cyprus, for the first 10 months of 2020, more than 1,000 deaths from smoking, 25 deaths with or by COVID-19. Actually, half of them I would have to attribute to smoking because these people died because of smoking primarily. Many thanks to all of you who were here today. Many thanks also to a number of my colleagues from around the world who have participated in some of the research work that I showed to you today. And I look forward to hearing your questions and trying to answer them for those that I know and learning for those that I do not know. Thank you.
Dr. Ioannidis, thank you very much for this wonderful talk, through which you have comprehensively covered almost every aspect of this global epidemic. It was an honor to have you on this panel of our symposium. I think it's great that we had the opportunity to listen to your talk. I understand that there are many questions on the chat. Obviously, we would have to address some of them, spend some time addressing some of the questions. I would like actually to take the opportunity to pose my own question first, and then we'll address the questions from the audience. I have this concern that a lot of measures are being implemented on this society without having scientific evidence to support it. And under these circumstances, I'm questioning whether even the governments under the power of the state could use their power to implement measures that are not scientifically supported on a global scale, on the whole population. Given that these measures do not have a backup, a scientific backup, how can they apply them on the whole population? Whereas instead, they could actually choose to consider these measures as a research hypothesis and implement them on a small scale under a specific scientific protocol with ethical considerations, and see whether these work before actually applying them on the whole population. So I would actually pose this question. I would greatly appreciate your comment on this.
I think that many of the measures that are being taken are completely meaningless. And I have to say, along with that, that I would never argue that someone should defy the law. So, you know, if a measure is a legal obligation, I believe in the Socratic approach that the law needs to be respected. Even if the law is wrong, even if the law is weird, even if the law is giving you poison to die, it's still the law. But I think that many of these measures are like poison given to Socrates. And it's not just poison given to Socrates. They're like poison given to the entire society, to the entire world, to the entire civilization, to the entire life and livelihood. So I would think that people who are in charge should really think very carefully about what they're doing. This is not just an infection. It's a situation that can destroy far more. And these measures have tremendous repercussions. You cannot really shut down the world like that. You're dealing with many reverberations and many repercussions, as I tried to highlight, many of them not very well known because we haven't really done that experiment. I heard about people saying that Sweden is doing an experiment. No, Sweden was doing probably what was the normal expectation. Everybody else was doing an experiment, or at least most countries that went into these severe measures. They were running an experiment that is devastating, to be honest, based on what we have seen now. I'm not going to blame anyone because we didn't know when we had to take these measures. So people asked me back in March when I highlighted that there's a huge danger. So you say that we should not do it. I said, of course, we have no option. It's like we're in the Middle Ages. We need to shut down and stay locked in our houses. But let's get some data. We have these data now. We cannot do that again. I see people talking about lockdown. I'm close to the point of screaming, It's completely unacceptable. We have ways to do things much, much better.
Yes. Yeah. Thank you. Thank you very much. There's a question about masks for children. From your review of the literature, would you comment on this, as well as Dr. Lazuras? Could you comment on masks for children from the mental health point of view? Dr. Ioannidis.
So masks are a highly contentious issue. Masks are effective for people who are infected. They are clearly effective for those people who get in touch. They have to meet and work and be exposed to people who are infected. And based both on work from my team and many other teams, we see that there's lots of people who are asymptomatic. They have no symptoms or limited symptoms. They don't realize it. That includes children. And they may spread the virus, some of them, a small proportion of them, and probably for children, it is even less. It is an even smaller proportion. So there is a risk there. And this is the rationale why masks are being proposed. Children will not suffocate by wearing masks. It's not that they will have physical damage to their lungs, to their brains, to whatever. Is it an effective measure? I think it's likely to be not effective. However, if this is a compromise for children to continue having their schools open and get education and not have that devastating effect of not having education, I'm willing to avoid saying that we have uncertainty and say, okay, let's do it. We want to keep our children at school. We want to socialize them. We want to make sure that they do get educated, that they do grow up really in a normal world with a mask, even though, to be honest, I'm not sure that for children, they're such a great idea. But I'm willing to adopt the lesser evil than the worse evil, which would be not to have education and socialization of our children, and obviously all the disruptive consequences for their parents.
There's also a question about the PCR, and I don't know if you would like to comment, Dr. Ioannidis, on the use of PCR, as well as I would like to add another level on that, to focus also on the positive predictive value of PCR, not only on sensitivity and specificity. Thank you.
So it's the first time that we're dealing with an epidemic, a pandemic, with massive use of PCR. We've never done that before. We had other tools. We had indirect epidemiological surveillance. We were trying to get a rough sense of, well, this year maybe about 500 million people were infected with influenza. It could be 10% more, 20% more or less. Now we are trying to capture every single case. I mean, this is both exciting and also horrifying. Because people are just fixating on these numbers, like 10 more cases, 100 more cases, 1,000 more cases, 1 billion cases, and it just makes no sense. If we had epidemiological surveillance that was rigorous, then I would say that knowing the number of infections and active infections would be very useful. In the current environment, I think that testing does make sense because you manage to detect people who have the virus, but as I said, we don't know who are those who are going to transmit, so probably we're quarantining far more than need to be quarantined, but that's okay. I mean, if we just tell people that probably you have nothing, but please stay at home for a few days, it's nothing. There's a slight chance, especially if they're old, with lots of very serious problems, it's not nothing to be exact, but the vast majority of the population, it's just nothing, but please stay at home. But don't commit suicide. We had a 40-year-old owner of an elderly care home in Athens who committed suicide, totally healthy. My goodness, he got a positive test and committed suicide, and this person had zero chance of having really coronavirus claim his life. So I think that we should not panic because of all these tests. A positive test very rarely will mean that you will get seriously sick, unless you are already seriously sick, and this is why you are testing yourself, but then you don't need to get the test to tell you that.
Yeah. And what about the positive predictive value of tests being done on the general population, where we know that the prevalence of the infection is very low?
Yeah, well, it depends on how you define infection. I mean, if you define infection as clinical syndrome, yes, most of the PCR tests mean nothing. They're false positives. But I don't want to see it this way, because it is a fragment of the virus that has been detected. So strictly speaking, it's not necessarily a false positive. But again, it's an issue of definition. We have that genetic material there. Most likely, it will not do anything to you. Most likely, you can just forget about it until you really feel sick. If you want to define it as false positives against clinical infection, yes, the false positive rate is just enormous. It's like 90% or more.
Okay. There's a very small question regarding the infection fatality rate of the flu virus compared to the coronavirus for those under age 70. Do you have information on that?
So as I said, we've dealt with the flu without going through all that super duper super technology PCR globally kind of panic hysteria and science combined. So we don't have exactly the same comparator information for the flu, but we assume that seasonal influenza has an infection fatality rate of about 0.1%. Based on surveillance, that bad years like 1957 or 1968 were about 0.2%. That Spanish flu was sky high compared to that. It was 3, 4, 5%. So the answer that I give to this, if you had a crazy scientist or a criminal who arrested you and said, now I'm going to torture you, you have to choose. You will be infected with influenza, or you will be infected with this new coronavirus. For someone, I'm 55, younger than me, I would say, oh goodness, I don't want to get anything of the two. No, you will be tortured. I would say if someone younger than me, let's take the coronavirus. Older than 55, I would take the influenza. Up to 65 and even older for people who don't have serious problems, it's not a big difference. But if I were a nursing home resident, if I had severe problems and I was elderly, then coronavirus would be devastating.
Mm-hmm. Yes. There are, we have another channel on YouTube that is broadcasted, simultaneously, and there are a lot of questions from those viewers from YouTube channel about these latest paper that you published regarding smoking. So they're asking, whether you could elaborate even more on that.
So it will be coming out. I said tomorrow. Actually, it's on the 26th.
Okay.
But I just give the example for Cyprus, but you can see it on a global level. Smoking is a $1 trillion business. 99% of the workforce is really being exploited by tobacco industry. They're paid pennies to grow tobacco and process it, and then about 1% of that workforce is making money, big money actually, paid that one trillion per year market, and I think that we have accepted that. We have accepted that we have 7, 8, 9 million people dying every year. We are expecting to have like 1 billion people die over 100 years unless we do something. The tobacco industry is growing. The market is increasing by 3%. During the pandemic, they did their best to grow their reputation. They donated ventilators. They said that we're saving the world. It is completely misleading. And we took all these measures. We destroyed everything for very little use, or who knows, maybe for a little benefit. And nobody said nothing. Nobody said, you cannot destroy my business. You cannot destroy my life. You cannot destroy my livelihood. We just accepted it. And we have companies that are making 1 trillion every year out of killing people that are still going on and are even building their reputation during COVID-19. So I think you should read the full paper with Prabhat Zha that I wrote. But if you really want to do something about public health, forget about coronavirus. I mean, coronavirus is a problem. We'll deal with it. We'll get rid of it. Do something about smoking, and something really, really drastic.
I would like to express my full gratitude to all the panelists who have accepted this invitation to be on this symposium. I'm honored to have participated in this symposium. And I would like to give the last opportunity for Dr. Ioannidis to conclude this symposium with his final remarks. Dr. Ioannidis, if you would like to consider at the same time a last question, people are asking about your position on the Great Barrington Declaration. Thank you.
Thank you, Elpidoforos. Great Barrington Declaration. It has been led by some amazing people. I know many of the leaders of the Great Barrington Declaration. They're amazing people. They're extremely well-intentioned. They really want the best for global health, for the health of everyone. And they have some very interesting ideas. I haven't signed it. I haven't signed also the counter declaration, which is the John Snow memorandum, where there's also lots of really great people, many friends also who have participated and have signed the John Snow memorandum. I haven't signed that either. And if I had to say, probably I agree about 70% with the Great Barrington Declaration and 30% with the John Snow Declaration. But for each point, I think that it would be a nuanced discussion. And what I really worry is that I see that there is very little tolerance in the community, in the scientific community, when people express different ideas and different positions. And I think that we need to work towards accepting debate, accepting what has been the norm for science all along. Personally, I love to be proven wrong. I consider people who show me that my arguments or my data are wrong and can be improved. They're my benefactors. I don't like, though, the sentiment that it is like a Manchester United versus Liverpool soccer game, that you will never become a Liverpool fan if you're a Manchester United fan. I mean, people need to be able to hear to alternative positions, alternative possibilities. I do believe that, as I showed you with all the data in my presentation, that if we can get a better future and a better outcome, this has to use some targeted precision, shielding, targeted protection. Some people would say this is impossible to do. I would say I think it is possible. The extent is how exactly we implement it and how do we get the most of different measures that could really save more lives and at the same time leave our society, our mental health, our physical health, our economy, our life undisrupted. So this is what we should all try to do. You know, rather than fighting each other and writing angry op-eds against each other and trying to come up with conflicts of interest that do not exist for our opponents, I think that we should just try to have all well-intentioned people be free to express their views, do their science, show their data, improve our evidence base, and join forces into doing our best, because there are conflicted entities out there. There's lots of stakeholders who will try to get the best for them under these circumstances where everything is just blown apart. So well-intentioned people, good people, should just not kill each other.
All right. Thank you very much for your wisdom, Dr. Ioannidis, and your wonderful presentation. Thank you all for your participation in this symposium, and hopefully we can move forward with this positive collaboration as Dr. Ioannidis is suggesting. Thank you all. Thank you. Good night.
Thank you.